to talk about specific challenges for people with HIV who are experiencing homelessness. So first, we're going to take a look at the current snapshot of HIV care among people experiencing homelessness. So people experiencing homelessness are 50% less likely to achieve viral suppression compared to those with stable housing. Viral load is linked to degree of housing stability, and barriers to care are compounded by competing priorities, prevalence of stigma, incarceration or being justice involved, mental health comorbidities, substance use disorder, and poverty. The graph on the right of the slide just shows the number of people living with HIV who are experiencing homelessness. What we can see is that there are many people who are sheltered but in transitional housing, even more that are unsheltered, and then the most people are accessing emergency shelters. What are clinical considerations when improving retention and care among people experiencing homelessness? So flexible scheduling and rescheduling without penalties for no-show can be really helpful. And along those lines, trying your best to see patients even when they arrive late, because we know that there's many barriers to getting to that appointment. That patient probably had to take a bus that maybe was running late, or maybe they, were having trouble accessing their medications at a shelter where they were living prior to coming to the appointment. So just having an understanding and being sensitive, people may be late or may not show, and it's often out of their control. Drop-in appointments can be very helpful. Support for enrollment into health insurance programs and AIDS drug assistance programs is critical as well, as oftentimes people don't have the means to do this themselves, especially if enrollment involves the use of the internet. Care that is available at a variety of clinical locations can be very helpful, rather than insistence that patients see specialists. This can be helped by sharing of data via the EMR. Transportation vouchers, use of rideshare services, flexible refill policies for lost and stolen medications. This is a huge problem among people who are experiencing homelessness. Stolen medications, lost medications are often reasons why people are not virally suppressed. And it's very hard to refill meds early. Practicing trauma-informed care, providing resources for syringe access and other harm reduction services. Lastly, providing wraparound support for other social determinants of health. And this may be done at the same time as ART initiation. So we've talked about the difficulties of medication storage in people experiencing homelessness who have HIV. We're going to dig a little bit deeper into that here. So patients often lack a secure space in which to store their medication. There's a lot of concerns around theft and getting a refill if medications are stolen. And this can really discourage retention and care, especially if a patient is experiencing challenges getting or keeping their medication. With so many other competing priorities in their life, it's important to make access to these medications as easy as possible. Medication adherence and retention and care can be improved by allowing patients to store their medication at the clinic or another facility, such as a facility that offers substance use disorder treatment. This also provides the added benefit of maintaining regular contact with the patient. Medication lockers may be available in certain cities. This is something I wish we had where I live. So who are potential partners for identifying and re-engaging people who are experiencing homelessness? There's so many options. Specialty clinics, outreach organizations that might go to the street and perform really intensive outreach can be great partners. Shelters or other housing services. Sexual health clinics. These clinics are often accessed by people who are not regularly engaged in HIV care and who need more flexible options for care, as sexual health clinics often operate on a drop-in basis. Substance use treatment centers. For example, people who are on methadone come to these centers daily, and this might be a great place to also provide HIV care. Syringe service providers. Our pharmacy partners can be a key collaborator in helping patients who have difficulty with medication access and adherence. Other community clinics or FQHCs and our local and state departments of health can also be key partners. So what are the effects of housing on HIV outcomes among people who are experiencing homelessness? In Washington, D.C., it was shown that people who are experiencing homelessness had significantly higher retention and care if they were receiving housing vouchers. On that same note, people experiencing homelessness with HIV in New York City who had access to rental assistance, housing placement assistance, and supportive permanent housing were nearly 3 times more likely to be retained in care compared to other people experiencing homelessness with HIV. People experiencing homelessness with HIV who transitioned to stable housing with the assistance of patient navigators and mobile interdisciplinary care teams also showed improved outcomes. The rate of retention was doubled. The likelihood of having prescribed ART was doubled, and people were 1.6 times as likely to achieve viral suppression. And this really supports the dogma that housing is healthcare. So here's a specific intervention that helped to improve retention and care among people experiencing homelessness with HIV. This describes the pop-up clinic in San Francisco. It's a low-barrier primary HIV care clinic. There's no need for scheduled appointments. There are financial incentives for visits and attaining HIV viral suppression. There's enhanced outreach via peer navigators and integrated social work and case management services. There's in-service clinical training and weekly clinician conferences to facilitate care coordination. Outcomes of people enrolled in this clinic were evaluated at 12 months. What we found is that 85% remained enrolled in the clinic, 70% had greater than one follow-up visit each 4-month period, 59% had greater than one gap of 90 days between visit, and that really tells us about sustained engagement. And then there were 12 median patient visits over 12 months. And I think what this really shows is that with an intensive intervention, clients who have a difficult time accessing care actually show up a lot, on an average of once per month. So what role can shelters and other community organizations play in retention and care? In my practice, shelters and community organizations can really be key partners in helping to outreach and identify those clients that really have the most barriers to care. And those tend to be our clients who are experiencing homelessness. Oftentimes, people are accessing these resources really on a consistent basis and have a lot of trust with the people who work there. This can facilitate a warm handoff to really jumpstart re-engagement and care.